So I think we need to think about the way forward.
Are we ready?
Yes, doctor, we are ready.
Good morning, everybody. You're really not happy with what we do, these online things. You find yourself talking to the screen or the laptop, and it looks very crazy. But we hope God will help us and everything will get back to its normal track, and we see you. So we have a short discussion today about the lens. So it will take us some short time, not as other, like the last one that we had on vitreous and retina.
Doctor, you're not hearing you.
So I'm saying that today we are going to have a very short, discussion. I don't know whether you're hearing me now.
Yes, doctor, we're hearing.
Yes, doctor.
Okay, good, thanks. It's not as long as vitreous and retina. This one is just short. So just let's give ourselves this short time and listen carefully, and then we can discuss. So we have to go through the brief anatomy, the functions of the lens, and then lens disorders. So if we can see the introduction, the crystalline lens is a transparent, symmetrically biconvex structure. That means both eyes, they have exactly the same structure, and it have both sides out. That's why we said biconvex. And it has a capacity to change its shape when a person is seeing, I mean, when you are focusing, either at a far distance or near. So it has that capacity to change its shape because it helps in visual acuity. So its posterior surface is attached to the vitreous by a ligament called Riget's ligament. That means the posterior part, the back part of the lens, the posterior capsule is attached to the vitreous. And the lens is placed between the iris and the vitreous. So that space we normally call the posterior chamber. That's where the lens is placed. If we talk of refractive index of the lens, that means the power that the lens has to focus the light. As the light comes through the cornea, then the power that the lens has to focus it to the retina is what we call the refractive index. So the power or the refractive index of the lens is 1.39. So now I said that the lens is between the iris and the vitreous, and it is attached to the vitreous. The posterior surface is facing the vitreous, but it is hanging kind of, and it has the zonules on both ends that holds it within in the space, and those zonules are attached or anchored to the ciliary body. So the lens is made of 1/3 protein and 2/3 water, apart from other minor constituents like maybe the sodium, the calcium, those exchanges, the glucose that takes place in the lens. So this 1/3 part of the protein and 2/3 part of water are the ones that makes that lens. So since the lens proteins, those proteins, the 1/3 proteins are antigenic in nature, that means they remain covered or sequestered inside an avascular compartment during the development of the immune system. It is covered, it is sequestered inside an avascular compartment during the development of the immune system. So that means the lens develops, when the immune system develops, it won't recognize the proteins those antigenic proteins, because they are always covered inside an avascular, no vessel supplying the lens. Because the lens gets its nutrients from by other means, from the vitreous, aqueous humor. So that one will give us a clinical significance that when a patient gets trauma and then the lens ruptures and then this protein now prolapses into the aqueous, into the immune system, now it will cause the body to react and have a very severe inflammation. That is why it has to be removed immediately after when there is trauma and lens rupture. So basically what you need to know is the lens anatomy that we're talking about, and we'll talk more about its structures, the structure parts and functions, the disorders of the lens. And basically the disorders of the lens at this time, you need to know much about the cataract. Some other few that I will mention about, but mostly the cataracts. And then we shall get to know about the causes and the types of the cataracts, and then the management, of which management is really surgical. There's nothing else that you can do as of today to treat cataract other than surgical. Good, so the human lens is composed of 4 basic structures. We have the capsule. The capsule, where it is enclosed, it has both the anterior and posterior parts of the capsule. So this capsule is elastic clear membrane enclosing the lens. It has anterior and posterior, as I said. Its main function is to mold the shape of the lens in response to tension on zonules. It's also an important barrier to forward migration of the vitreous during and after lens extraction. So this is, if the posterior capsule, which is at the back part, which is near the vitreous, if it's not ruptured, you do cataract surgery, you remove other things as we shall see, and then the vitreous will not flow or will prolapse into the anterior chamber because that posterior part is protecting it to come. That's what they say, but it is a barrier, it's an important barrier. But if there is a rupture of that posterior capsule during surgery, then this will cause the vitreous to come, prolapse within the anterior chamber. So the lens has the epithelium, which is a layer of cells lying beneath the anterior lens capsule, the epithelium. It has the cortex. The cortex is a clear protein material that we talked about, forming the bulk of the lens and surrounded by the lens capsule. And then it has the nucleus. This is the central part of the lens, which is soft in infancy and childhood, and it becomes progressively harder with age, leading to some funny lens disorders like presbyopia. Presbyopia, that means you cannot read nearer. I mean, when you are going to read, you see some people, old people, if you observe properly, is going to read on the phone or maybe in the newspaper, and he puts that newspaper far from himself or herself. That means the lens has hardened and it cannot extend or contract very easily. So here we have the part that this lens, we have the anterior pole. This is the anterior cap. This is where the anterior capsule is, the surrounding capsule. That is the anterior capsule. We have the cortex, which is surrounding, that is the protein portion that is covering or surrounding the nucleus. We have the epithelial cells. You can see the epithelial layer under the anterior capsule. We have the posterior pole down there. That is the part that is facing the nucleus. And then the rest are just equator. This is where the equator is in both ends. That's where the zonules are, and they are anchored or attached to the ciliary body and keeps this lens hanging in its position. So what are the functions of the lens? So the functions of the lens, of course, depends on its character or these points here, the transparency. So lens transparency is maintained because of the ordered structure of the lens fibers. It has a single layer of epithelium, and it has a semi-permeable capsule. So that means the single layer, well arranged, it allows the light to go through properly without an interruption through the be focused properly to their retina. And being a semi-permeable capsule, it allows the nutrients that are from the vitreous and this aqueous humor to go in properly, to do those the nutrient exchange to be done very easily. We talked about the power of the lens, which is the refractive index. This helps us to focus light. So the lens have a refractive index that is different from the medium in which it is suspended, like around in the vitreous, in the posterior chamber, where posterior chamber we have the aqueous humor. So the refractive index, the power of the lens has to be more than the power of the fluid that is surrounding it, so that it is able to converge, to reflect the light and focus it to the retina. So it has that ability to change shape during accommodation. We talked about that it changes its shape. So when it changes its shape, when it enlarges, the power increases, the index, and then it refracts light rays more, and then they converge very near, and then a person is able to read near, to have near vision, or to read from shortest distance. And when it relaxes, when the zonus relaxes and changes, when it changes shape and it's in the relaxation form, then the refractive power of the lens decreases, and then the light is less refracted, and rays are focused and converge somehow far away from the lens itself, and that is at the retina, at the macula. And then that helps a person to see clearly at a distance. So that's all about what we wanted to know about the lens, its structures, its anatomy, and then functions. So let's see the lens disorders. I talked about the cataracts. We'll talk about the abnormalities of lens shape, which you have this subluxated and dislocated or ectopic lentis. But we shall be much concerned with the cataracts. Sorry. So what is a cataract? I'm sure you all know, because you guys, you read. So when the natural lens opacifies, that's when we say it is cataractus. So most lens opacities are small and do not interfere significantly. At that time, when maybe the patient is 6'18", 6'12", 6'9", it's very possible, and you see some cataracts, probably posterior capsule, subcapsular cataract, or maybe early cortical cataracts, or maybe early nuclear opacification, and then the patient is still having that vision, unless he's very active, maybe he's a driver, maybe he reads books, and then he finds it is somehow interfering. That's when we go in for surgery. But other people, when you have 6'12", when it's not really good, or 6'9", to rush and they say you have to remove the lens, keeping in mind that surgery, you can get some complications. So the visual loss from cataract, other than cataract resulting from trauma, is gradual, progressive, and painless. But when it is trauma, in most cases, it is sudden. But other types of cataracts, like senile cataract, that is age-related, maybe due to diabetes, maybe due to some other, it will take some time. The patient will come and say, you know what, I've been seeing well, but all of a sudden in 6 months or 2 months, that's when my vision is completely off. But it started slowly. So that's what we call the gradual progression. So we have some terminologies that we use. When you talk of aphakia, this is the condition of the eye without the lens. And an eye that has undergone surgical removal of cataractus lens is aphakic. That means it has been done cataract surgery, or maybe there was trauma and there was the dislocation of the lens, and the lens, the natural lens, has not been replaced by an artificial lens. So we say it is an aphakic eye, meaning the eye with normal crystalline lens, natural crystalline lens, we call it phakic eye. So an eye that has had surgical removal of the cataractus lens with implantation of an artificial intraocular lens, which we abbreviate as IOL, is called a pseudophakic eye. So, what are the causes of cataract? We have acquired cataracts and we have congenital cataracts. So in acquired cataracts, that means it can be due to age, because when we are aging, our cells degenerate. So the lens cells also start degenerating and they cannot be replaced. And then they become opassifying, and then we get that cataract. It can be due to trauma. It can be due to metabolic diseases. A good example is diabetes mellitus. It can be due to drugs. When you have prolonged use of steroids, at the end of the day, you develop cataract. It can be second with other ocular diseases like uveitis, the inflammation of the eye. The uveitis tissues, you have iris, the ciliary body, those things, even the retina, we call them uveitis tissues. So sometimes when the inflammation is going on, then it can lead to opacification of the lens and get cataract. It can be congenital, genetical and metabolic diseases like Down syndrome, we shall see them. It can be due to torch disease, the rubella, the syphilis, or toxo that the mother can get during pregnancy. It can be hereditary cataract. So those are the major, the causes, maybe, or the etiologies of the cataracts. Then we have classification. Cataracts can be classified according to different things. Generally, there are numerous ways that cataracts can be classified, and can according to either age, as we said in the previous slide. So, age of the patient at onset. If the cataract comes maybe at an early age, that is the child was born with clear lens, but probably at 2 years or what and develops that cataract, we can call it infantile cataract. Or it can be developmental. Infantile is when it is less than 3 years. Developmental, it is when it starts around 10 years or 10 years there. It can be familial, developing in childhood, or early adulthood. So adult onset cataract is also known as senile cataract. And this is by far the largest group. So it can be according to etiology. Cataract can be classified according to etiology. As we said, it can be traumatic, it can be congenital, it can be metabolic, it can be secondary to other uveitic diseases we talked about. It can be due to excessive and prolonged use of corticosteroids. There are some cataracts, they come to us, patient is around 40 years, you don't expect to be developing senile or age-related. He says no history of trauma, no systemic disease, but he has that uncomplicated cataract. So that one, we don't know the cause. And then we have the complicated cataracts. This is a collective term for cataract second with a known condition such as trauma, uveitis, or diabetes. Why do we call it complicated cataracts? Some other associated condition, signs. If it is maybe traumatic, because of inflammation, and maybe it has taken long, the patient has taken long to come because the lens was not ruptured to cause that much inflammation, but there's some mild inflammation due to trauma. You find now the iris is adherent to the lens, anterior part of the lens. And that one we call the posterior synechiae. So that cataract is a bit complicated when you're going to do surgery. Yeah, even in uveitis, because of the long-standing inflammation of the uveitis tissues, it causes such a funny formation of the adherence of the lens and the iris. So it can be classified according to anatomical position. So if the hardening and opacification starts within the nucleus, we say there is capsule, there is a nucleus, and there's cortex as parts, major parts. So that one, we call it nuclear cataract. If the surrounding cortex is the one that starts hardening and becomes opaque, we call that one the cortical cataract. And if in most cases, the part of the nucleus that is near the posterior capsule, if it is that part that is really opacified, you see through the anterior capsule, you see through the nucleus, the part of the nucleus in the center, it is a bit clear. But when you reach the posterior part, not the capsule, please note me well, not the capsule that is opacified, but the nucleus, the part of the nucleus which is near the posterior capsule is the one that is opacified. Then we call that one posterior subcapsular cataract. So we can as well classify cataract according to the location of the lens. Now, not the location of the opacification in the parts of the lens, but the location of the lens itself. The lens can be cataractous and laxated or dislocated when the lens is completely out of position. That means zonules both sides are broken and you feel your chamber or in the posterior chamber within the vitreous. Oh, my internet is not well. I don't know. Are you still hearing me?
Yes, doctor. Yes, doctor, we can hear you. Doctor, we can hear you.
Yeah. Okay, please. Then it can be partly out of position, and that's when we call it subluxated. The other one is luxated or dislocated. This one is subluxated. That means maybe the part of zonules, at the one end is broken, and then the other end zonules are intact. So the lens is hanging either posteriorly or anteriorly. So it also cataracts can be classified according to the density of the cataract. We call it incipient cataract. This early lens opacity may cause little or no decrease of visual acuity. This is why we don't need to go rush into do cataract surgery. We call cataract immature when the opacity is present and it can cause minor visual disturbances. Here, if the patient is a driver, if the patient is a reader, somebody who likes reading, writing, then that one will be disturbed. But if he's a farmer, you find it's not even disturbing because immature cataract, still you can have a vision of 6/12. And that one in his village, you can see the cows, you can see the plantations, you can see, you don't need to go for surgery immediately. So when the cataract appears whitish or milky and the vision is greatly affected, this time around we call it mature cataract, no option, just go to theater. So mature cataract can be intumescent. Here the lens is milky and swollen. It can be milky, that is appearing whitish but not swollen. But when it is swollen, then we call that one intumescent cataract. I mean, it is like there's a bulging of that lens because the lens contents within the nucleus are increasing and accumulating. It can be hypermature cataract. This one the lens appears in the people as completely white, but here the lens, the nucleus inside is shrinking. When you see properly, you will see that white anterior capsule, but there's a nucleus which is a small thing within the center, just dancing. So we can call it Morganian cataract. Here the cortex has liquefied already. There's no cortical matter. And the support for the hard nucleus is lost. So it's completely floating within the fluid cortex between the capsules, the anterior and posterior capsule. And when you look at the nucleus, it is now dark brown. So this one we call it Morganian cataract. This hypermature cataract and Morganian cataracts, they are not good cataracts when we are teaching, when people are starting to do surgeries. Because the capsules are very weak, so it's very easy to rupture the posterior capsule. And now we end up getting vitreous loss you end up failing to get where to put your artificial lens, because the artificial lens is placed on the posterior capsule of the lens. So just brief on pathophysiology of these cataracts, both the age-related and the diabetic. So aging and ultraviolet light exposure are associated with marked increase in lens membrane permeability with liquefaction of lens material due to osmotic phenomenon. The lens intumescence that we are talking about, there is liquefaction of lens material. The exposure to ultraviolet or age, it increases the lens membrane to be permeable, a lot of things going in. And then there is liquefaction of the cortex, mostly. And then the opacification sets in very easily. If it is due to diabetes, we have the two ways. We have osmotic effect and we have the direct damage. So in osmotic effect, the glucose through its pathways, the Krebs cycle, it changes into sorbitol via aldose reductase. So now the sorbitol now cannot diffuse out of intracellular compartment of the lens. There is the reduction, the disturbance in the aldose reductase enzyme in diabetes. And then the sorbitol that has been converted, it remains, it accumulates within the lens. And then now it will cause the osmotic effect to the lens material, the proteins, and they start to opacify. So when it accumulates in the lens, it creates that osmotic gradient. And then the cells start swelling, and some of them, they rupture. And when they rupture, definitely they are now damaged and they are opacified and cause cataract formation. So in direct damage, the glucose mainly directly interact with the lens proteins via glycosylation and cataract formation, because the cells, when the proteins aggregate, then they change their they change the nucleus. This takes place within the nucleus. That is just a short about its physiology. So when the cataract is formed, there is nothing you can do apart from sun. This is now we have cataracts and we put our further vision. Stroke is one of the most common. 90% or 95% is successful. That is, that's a percentage where you have complications.
Attending.